In this video, we will focus on those who should have weight loss surgery and then those who should not. Obesity poses grave risks to the individual. It affects the quality of life. It is associated with a large number of comorbid conditions. It reduces lifespan and it may lead to psychological issues. Consequently, cost to the society in the US has been estimated to $200 billion a year, which is a large chunk of the healthcare budget. Lastly, health tourism is on the rise, which means people are traveling great distances to have obesity surgery in other parts of the globe, where it is supposedly cheaper. It is best to arm yourself with the facts before embarking on such missions. I cannot stress enough being treated by a multidisciplinary team who is experienced in managing obesity and obesity-related complications to be able to derive full benefit in a safe environment where complications are anticipated and that when they arise are treated effectively. One of the most important measures of obesity, that is excess fat that we are carrying, is the body mass index. It is a simple calculation. It takes into account the weight of the individual measured in kilograms and then height of the individual in meters, and the weight is divided by height in meters squared. A measure of 18.5 to 25 is normal, 25 to 30 is overweight, 30 to 35 is class 1 obesity, 35 to 40 is class 2 obesity, and a BMI of over 40 is class 3 or severe obesity. So here are the broad indications for patients who may be suitable to undergo obesity surgery. These have been developed by a number of professional organizations, notably the National Society of Metabolic and Bariatric Surgery, supported by the National Institute of Health in the United States, and these are very similar to those adopted in Europe and other parts of the world. Anyone with a BMI of greater than 35, that is class 2 obesity, those with a BMI of 30 to 35, that is class 1 obesity, but with type 2 diabetes, and finally those with class 1 obesity, BMI 30 to 35, but they have been unable to alter their disease course despite attempting lifestyle and diet interventions for a 3 to 6 month period. All of these are potential candidates for considering obesity or bariatric surgery. Now, the caveat is that these BMI thresholds are lower for the Asian population. These apply to the white European origin. I am going to further elaborate on this group. What disease course are we talking about other than type 2 diabetes? So here's a list of complications that, when present, should lead to the consideration of having surgery for obesity. So we've already discussed type 2 diabetes, cardiovascular conditions such as coronary artery disease and high blood pressure, hyperlipidemia, high cholesterol, etc. Respiratory diseases such as asthma, obesity hypoventilation syndrome, where patients are unable to shift enough oxygen to their lungs, obstructive sleep apnea, arthritis, degenerative joint disease, pseudotumor cerebri, cause or idiopathic intracranial hypertension, depression, reflux, esophagitis, fatty liver disease, gallstones, non-alcoholic inflammation of the liver called steatohepatitis or cirrhosis of the liver, stress-related urinary incontinence, venous stasis leading to deep vein thrombosis, pulmonary embolism, or recurrent superficial thrombophlebitis, hernias caused by or made worse by severe obesity, and gynecological such as irregular menstruation, polycystic ovary disease, infertility, gynecomastia in men, and hirsutism. Obesity clearly increases the risk of cancer, notably colon, prostate, uterus, and breast, as well as an increased risk of several infections. Hence, presence of one or more of these is a cause for candidacy for obesity surgery. Now, which patients should not have obesity or bariatric surgery? That is, if their BMI is not high enough. So they have the risk factors, but their BMI is not high. Patients with untreated major depression or psychosis, uncontrolled and untreated eating disorders such as bulimia, current drug or alcohol abuse, severe cardiac disease, and prohibitive anesthetic risk. What does that mean? These patients are not fit for other reasons to undergo an operation. Severe coagulopathy, which means that there is an issue with their blood clotting, which cannot be corrected. And finally, inability to comply with nutritional requirements, including lifelong vitamin replacement. All of these surgeries that patients undergo for obesity have lifelong consequences and require full patient cooperation to get the best results in the long term. And if patients are deemed unable to comply, then perhaps bariatric surgery is not best for them. Okay, so what about age? So there is no upper limit. provided patients are fit enough and meet with the conditions, then obesity surgery may be considered. Increasingly, obesity surgery is being performed in appropriate multidisciplinary centers in patients younger than 18, and so far with good outcomes. What if once patients are seen in obesity specialist centers and awaiting surgery they lose weight and then no longer meet the criteria? Such patients should have a careful discussion with their healthcare providers, understanding the risks and benefits. In general, entry weight is the one to consider when making a decision about whether or not a patient should have surgery. So most programs may still consider obesity surgery even if patients have lost weight. But this decision should be made very carefully, taking into account patient preference and understanding what it entails in terms of risks and benefits of surgery. Just because a patient meets the disease criteria does not mean that surgery should be the next step. In a specialist center, the patients will then undergo a full assessment, weighing up all the risks, and these include the following: psychosocial, screening for eating disorders, substance abuse and alcohol abuse, mental health, depression, psychosis, as well as provide a service after surgery to meet with the new challenges that I will discuss in another video. A full nutritional assessment of weight and eating habits, the medication that may impact weight preoperatively and postoperatively, the body composition and energy and caloric requirements both before surgery and after surgery, anticipating micronutrient, vitamin, mineral deficiency and targeted correction, a full medical assessment, metabolic such as type 2 diabetes, thyroid disorders, heart and lungs, and finally laboratory assessments such as kidney function, which may be affected by obesity, diabetes control with glycosylated hemoglobin, a lipid panel assessment for gout and thyroid. All patients will undergo an assessment and screening for obstructive sleep apnea, which is a common condition with obesity and often undiagnosed, hypertension and coronary vessel disease, a full assessment if required, gastrointestinal such as reflux, gastritis, combining with pH studies to monitor how severe the problem may be, cancer screening because of the risks associated, and finally a specialist anesthetic team assessing from their perspective to be able to cope with the special challenges that arise in such surgery. To improve the safety of the surgery and to get the best chance of recovery, a period of preparation is essential. All such patients should undergo an exercise, diet and weight loss program in the run-up to the surgery, both to reduce their own risk from surgery, but also to prepare them for their life after they have had an operation. Smoking cessation has a huge benefit, and patients who are able to give up smoking, despite 20 to 25% going back to smoking over the long term, it certainly improves the risk associated with an operation. The recommended stoppage of all alcohol intake up to a year before surgery is recommended. However, alcohol should be stopped altogether as soon as a decision is taken to undergo the operation. Patients who are taking extraneous estrogen, such as birth control, implants, or for HRT, are best stopping it 4 to 6 weeks prior to their operation, depending on their local guidance, to reduce the risk of venous thromboembolism. Most programs will require patients to undergo preoperative weight loss through low or very low caloric intake in the run-up to operation. That may be from 2 to 6 weeks. What it does is that it reduces the volume of liver and thus eases the technical complexity of the operation. Sometimes the fatty liver is such an impediment that safe surgery may not be performed. Hence the term liver shrinking diet. In specialist units, patients are offered and should utilize the prehabilitation program for 4 to 12 weeks prior to the operation, where all of these are combined, and often group activities encouraged so that there is camaraderie and compliance. And finally, patients ought to have access to counseling and advice. Mental health issues with obesity are very common, and the real challenges offered by surgery and its aftermath require long-term patient support. So in conclusion, it is essential for each patient to be able to make the decision whether or not surgery is the right way forward for them. It is essential to be under the right team that includes specialists such as surgeons, specialist physicians, counselors and psychologists, dietitians, specialist nurses, and access to obesity related special measures in the operating room, including the anesthetic team. And it is through a combined effort of such teams that excellent outcomes are achieved in the long term. And if you prepare well and choose the right team, there is every chance of achieving the goals that you set for yourself. This ends this video. If you have any comments, please do share.